Your doctor checks your blood pressure, says 148/78, and you think, okay, the bottom number looks fine. I'm probably doing all right. I hear some version of that every single week in my practice. Here's something worth knowing. A major analysis of over 1 million adults found that every 20-point rise in systolic pressure, that top number, doubles your risk of dying from a heart attack or stroke. Doubles it. I'm Dr. David Okafor. I've spent over 20 years in internal medicine working with patients over 60, and I can tell you that habit of looking at the bottom number and feeling reassured has put people in the hospital when they thought they were doing fine. The number that actually matters after 60 is not the one most people are watching. And there's one reading pattern, I see it almost every week, that nobody ever explains to you. Your doctor sees it on the chart. Most of the time, nobody says a word about it. That's what today is really about. Stay with me on this one. Before we get into it, drop your numbers in the comments. Your top number, your bottom number, and how long it's been since you checked at home, whether you're 62, 71, or 84. I read every single one, and honestly, the conversations down there are half the reason this channel exists. People helping each other figure this out. All right, so that top number and that bottom number, what are they actually telling you? Because after 60, the answer changes. Blood pressure after 60 is a different conversation entirely. Most people learn about it in their 40s, cut back on salt, keep moving, life goes on, but the way your cardiovascular system handles pressure changes as you get older. What was manageable at 45 can be quietly dangerous at 65. Same numbers, different body, different risk. So let's get the basics right. When your doctor reads your blood pressure, you get two numbers, 148/78, for example. That first number, 148, is your systolic pressure, the force your heart creates when it squeezes and pushes blood out into your arteries. Think of it as the peak pressure, the moment of maximum effort. The second number, 78, is your diastolic, the pressure when your heart is resting between beats. For decades, medicine focused heavily on that bottom number. Diastolic hypertension was considered the main threat. But something shifts after 60, and it changes which number deserves your attention. Here's what happens inside your body over time, and this part is actually fascinating once you see it. Imagine your garden hose in spring. Flexible, soft. You squeeze it, and it bounces right back. Now picture that same hose left outside through 10 winters, rigid, brittle. You bend it and it cracks. That's your arteries after decades of use. Not because something went wrong, because that's biology. Collagen fibers gradually replace the elastic tissue, or more precisely, the elastin in your artery walls. The walls thicken. The vessels lose their ability to expand when your heart contracts. When you're young, healthy arteries act like shock absorbers. They stretch slightly with each heartbeat, then spring back. The peak force stays controlled. But stiff arteries can't do that anymore. When your heart pushes blood out, there's nowhere for that pressure wave to go. It hits a rigid wall and bounces back, hard. Your systolic number, the top one, spikes. Meanwhile, your diastolic, the bottom one, can actually drop or just sit there flat. And this is where people get dangerously confused. You see a high top number and a normal bottom number, and you think, well, the bottom one's okay, so how bad can it be? It can be very bad. That pattern has a name, and understanding it might be one of the most important things you take away from this video. Isolated systolic hypertension. Your top number consistently at or above 140. Your bottom number below 90. Normal bottom, high top. After 60, this is the most common form of high blood pressure. It accounts for roughly 80% of all hypertension cases in that age group. Here's something that research has confirmed clearly, but that most routine appointments never have time to cover. This pattern is not a quirk of aging. It's not something to accept and move on from. It is one of the strongest predictors of heart attack, stroke, and heart failure in adults over 60, stronger than elevated diastolic alone in this age group. Remember that number from earlier? Every 20-point rise in systolic doubles your vascular mortality risk. So think about someone sitting at 160 systolic, pointing at their 75 diastolic and feeling relieved. That relief is misplaced. The risk is sitting right there in the top number. When's the last time you actually checked your top number at home, not just at the doctor's office? And if your readings look something like 150/70, a high top and a notably low bottom, stay with me. That gap between the two numbers has its own story, and it's one that almost never gets explained. Let's talk about that gap. Your pulse pressure is simply the difference between the top number and the bottom number. So if you're reading 150/70, your pulse pressure is 80. And when that gap gets consistently wider than 60, that's a signal worth paying attention to. You might be thinking, my doctor told me 150/70 is fine because the bottom number is good. That is not the full picture. A wide pulse pressure means your large arteries, especially the aorta, have stiffened to the point where they're no longer absorbing the shock of each heartbeat. Every beat slams harder into your organs. Research from the Framingham Heart Study found that every 10-point increase in pulse pressure raised the risk of a major cardiovascular event by roughly 31%. Now, in some cases, a widening pulse pressure combined with symptoms like shortness of breath or a new heart murmur can point to something specific, an aortic valve that isn't closing the way it should. That's worth checking with an echocardiogram, a painless ultrasound of the heart. I'm not saying everyone with a wide gap has a valve problem. Most don't. But this is a number your doctor sees on the chart at every visit, and most of the time, nobody mentions it. If your top number minus your bottom number is regularly above 60, that's a conversation worth starting. And now you know what to ask about. So now you know what to watch. But knowing the number is only half of it. What does a stiff aorta and a wide pulse pressure actually do to you day after day? Let's start with the brain, because this part doesn't get nearly enough attention. Your brain runs on a constant, carefully regulated blood supply. Tiny vessels, some thinner than a human hair, feed billions of neurons around the clock, and those tiny vessels are the first casualties of chronic high systolic pressure. Every surge at 150, 160 sends a small mechanical shock through those vessels. Once in a while, manageable. But when that happens tens of thousands of times a day, for years, those vessels begin to thicken, narrow. Some develop tiny tears. Some just close off. Small areas of brain tissue quietly lose their blood supply. You don't feel it. There's no dramatic moment, just a gradual, invisible erosion. And then one of two things happens. Either a larger vessel gives way, that's a stroke, or the cumulative damage builds slowly into something that looks almost exactly like Alzheimer's disease. Vascular dementia, dementia caused by damaged blood vessels in the brain, is the second most common form. It accounts for roughly 1 in 5 cases. The memory lapses, the confusion, the personality changes, they can look identical to Alzheimer's in the early stages. I'll be honest, this one used to keep me up at night when I first started seeing it in my patients. But here's the key difference. Unlike Alzheimer's, vascular dementia is substantially preventable. Controlling your systolic pressure is one of the most powerful tools we have to protect the brain. Think about that for a second. Some of what we accept as inevitable aging was entirely within our control to slow down. High systolic pressure doesn't stop at your neck. It's a whole body problem. Start with the heart itself. When systolic pressure is chronically elevated, your heart works harder every single beat, pushing against higher resistance, every minute, every day. The heart muscle responds the way any overworked muscle does. It thickens. The left ventricle gets bigger. Sounds like it's getting stronger, right? It's getting worse. A thickened heart muscle becomes less flexible, fills with blood less effectively between beats. Eventually, heart failure. Then your kidneys. They filter your entire blood supply dozens of times a day through tiny vessels. Years of high systolic pressure quietly damages those vessels, gradually reducing kidney function. The trap? You don't feel it until significant damage has already happened. In your eyes, the retina is lined with small blood vessels that are highly vulnerable to pressure damage. Hypertensive retinopathy can degrade your vision silently for years. Brain, heart, kidneys, eyes. And here's what gets me. You don't feel any of it, not until it's gone too far. Quick pause. If this is putting some pieces together for you, take 1 second and hit that subscribe button. It genuinely helps this reach more people over 60 who need to hear it. All right, let's keep going. So, where should your number be? For most adults over 65, current guidelines set the target at below 130 systolic, not 140, 130. Oh, and I should mention, some of you over 80 may hear a slightly different number from your doctor. That's okay. The principle is the same, lower, within your safe range. For years, doctors accepted higher readings in older patients. The thinking was, some elevation is just normal aging, don't push too hard. Then a trial called SPRINT changed the conversation. SPRINT followed over 9,000 adults at cardiovascular risk. The group treated to below 120 systolic had 25% fewer heart attacks, strokes, and cardiovascular deaths. 27% fewer deaths overall. The trial was stopped early because the benefit was so clear they couldn't ethically keep the other group at the higher target. Your doctor will calibrate your personal target based on your full picture, your other conditions, your medications, your tolerance. But the direction of the evidence is not ambiguous. Lower systolic, within a safe range, saves lives after 60. So, where is your number sitting right now? Do you actually know? Good news is, there are things you can do about it this week. No prescription, no appointment, starting tonight if you want. First, sodium. This one matters more after 60 than it ever did before, and here's why. Your kidneys clear sodium less efficiently as you get older. Salt hits your pressure harder now than it did 20 years ago. The target is 1,500 to 2,000 milligrams a day. 1 teaspoon of salt contains 2,300. And the biggest offenders aren't the salt shaker, they're bread, canned soups, deli meats, and restaurant meals. Those 4 alone can push you past your daily limit before dinner. Second, weight. Every excess 10 pounds raises systolic by about 4 to 5 points. Lose those 10 pounds, it comes back down. Not aesthetics, hydraulics. Third, aerobic exercise. 30 minutes of moderate activity, brisk walking, cycling, swimming, 5 days a week can lower systolic by 5 to 8 points over time. And here's the part people miss. Regular movement actually slows the stiffening of your arteries. Remember that rigid garden hose? Exercise is one of the few things that genuinely maintains the stretch in your artery walls. That is not a metaphor. That's the actual mechanism. Fourth, stress management. Chronic stress keeps cortisol and adrenaline elevated. Both drive systolic up day after day. Structured relaxation, meditation, deep breathing, even regular time in nature can lower systolic by about 5 to 7 points, comparable to a low-dose medication. What's your weakest area out of those 4? That's exactly where your biggest opportunity is hiding. A little later in the video, I want to tell you about a patient of mine who did one simple thing, tracked her numbers at home for 7 days, and what that habit uncovered changed her entire treatment plan. Now, I need to address something head on, because I hear it constantly. They just keep adding pills. If I tried harder, ate better, exercised more, I wouldn't need them. I understand that feeling. I genuinely do. And there's a whole cultural narrative behind it. This idea that needing medication means you failed somehow. That willpower should have been enough. I want to take that apart because it's keeping people from protection they actually need. After 60, arterial stiffness is a structural change. Collagen replacing elastic tissue at the cellular level. That's permanent biology. Lifestyle changes can slow that process, reduce its consequences, and they matter enormously, but they cannot fully reverse it. A 65-year-old artery wall is not going to become 30 again. The biology simply won't allow it. For many people over 60 with significant systolic hypertension, lifestyle alone doesn't get them to target. That's not a failure of willpower, that's biology. I have patients who walk 5 miles a day, eat beautifully, manage stress consistently, and they still need medication to keep their systolic reliably below 130. That is not failure. That is their biology, and they are responding to it intelligently. ACE inhibitors, calcium channel blockers, thiazide diuretics, among the most studied medications in the history of medicine. Take yours consistently and without guilt. Now, the single most underused weapon in blood pressure management after 60. It's not a drug, it's not a diet, it costs nothing. It's your home blood pressure monitor and the simple habit of using it correctly. But first, here is something they teach on day 1 of medical training, and then the system quietly ignores it. Before your blood pressure is measured, you're supposed to sit quietly for at least 5 minutes, feet flat on the floor. No talking, no phone, just sitting. How many of you have ever been given those 5 minutes before they put the cuff on? I'm guessing almost none of you. The simple act of walking into the office, sitting down, and having the cuff go on immediately can inflate your systolic reading by 20 to 30 points. That's not a small error. That's the difference between 128 and 155, between you're fine and we need to add another medication. This is called white coat hypertension, and it affects somewhere between 15 and 30% of patients. Your doctor sees 155. You go home and you're 128, very different picture. But the reverse happens too, and it's more dangerous because nobody catches it. Masked hypertension. Looks fine in the office, running 150 at home, consistently, and nobody knows because nobody measured it there. I want to tell you about a patient of mine. I'll call her Helen, 68 years old, retired school teacher. She came to me worried. Her regular doctor had been measuring 155 over 72 at every visit for 2 years. Added a second blood pressure medication. She said she felt worse, not better, more dizzy, more tired. I asked her to do one thing: buy a validated upper arm cuff, not a wrist one, sit quietly for 5 minutes, and take 2 readings, a minute apart, morning and evening, for 7 days. Write every number down in a notebook. She came back with that notebook, and it told a completely different story. Her home average, 128 over 70. The office reading had been inflated the entire time, white coat effect, no rest period, rushed measurement. She'd been taking a medication she didn't need for a problem that looked completely different at home. We pulled back the unnecessary second prescription, switched to consistent home monitoring. Research shows home readings predict cardiovascular risk more accurately than office readings, and in Helen's case, that simple notebook gave us the truth the office never could. She told me, for 2 years I thought something was getting worse. Turns out the measurement was getting worse, not me. Here's the protocol. It takes 5 minutes. Buy a validated upper arm blood pressure monitor. Sit quietly for 5 minutes before measuring. Take 2 readings, 1 minute apart, morning and evening, at roughly the same times each day. Write down every single reading. Bring that log to every appointment. That log is worth more to me as a clinician than 100 office readings. It shows me your real pressure during real life. Most videos end by telling you to talk to your doctor. I want to do something more useful than that. I want to give you 3 questions to bring with you. Write these down. Number 1. What is my pulse pressure and has the gap been getting wider? That ties back to everything we just covered about wide pulse pressure and what it signals. Number 2. Was I sitting and resting for at least 5 minutes before you took this reading? If the answer is no, you now know what that means for the accuracy of the number. Number 3. What is my specific systolic target and why that number for me? Not a general guideline, your number. Based on your history. 3 questions. Write them on a piece of paper. Bring it to your next visit. You've earned the right to ask, and your doctor, the good ones, will respect you for it. Here's what I want you to do this week. Just one thing. Check your systolic at home twice a day for 7 days. Morning and evening. Write every reading down. You might be surprised by what the numbers actually show when nobody's watching. And if this gave you something useful, share it with someone over 60 who needs to hear it. A partner, a sibling, a friend. This kind of information changes outcomes. I've seen it over 20 years. Everything I've shared today is general medical information. Your doctor knows your full clinical picture, and that context matters before you change anything. Take care of yourself, and take care of the people around you.